Hello and welcome to another of our new series of events called Look Who's Speaking. We organize this series of talks on different issues once a month to provide clarity on different issues on kidney disease, organ donation, and other topics. My name is Hilaria, and I am the founder and chair of WSH BME Kidney Network. And with me today, moderating this session is Theo Asumo. You all already know him. He's been in other sessions we've organized, supporting, advising, and guiding the charity. The charity is based in Manchester, and we provide advice, support, advocacy, and education to kidney disease and transplant patients and their families who find it difficult navigating government systems and institutions. We also campaign and raise awareness about organ and blood donation. So today we would like to welcome to our platform Alex Obo. Theo will introduce him later. Alex will talk about understanding menopausal symptoms in women with end-stage kidney disease and transplant. I hope that by the end of the session, it will allay some anxieties some transplant patients, especially patients with of childbearing age, the anxieties they have when they have symptoms similar to menopause. Before I hand over to Alex, I would like to go over the housekeeping for this event. This session will run for approximately 1 hour. Alex will speak for 30 minutes. Then there will be a question and answer session with Theo, who is the moderator for today. If you have questions in the meantime, put them in the chat box and we will answer them at the end. If you'd like to come on to ask a question, either raise your hand or post in the chat and I will bring you on to into the session. Thank you for listening to me. I'll hand over to Theo and welcome Alex to Wish BME Kidney Network platform. Thank you for giving us your time today. Okay, over to you, Theo.
Thank you very much, Hilary. So as Hilary said, our speaker this afternoon is Dr. Alex Obo, who is a Nigerian doctor who did his primary medical training in Nigeria and qualified as a doctor from the University of Benin, which happens to be the same university I attended. So it's with some pride I associate with him. Following his basic medical qualification, he pursued his postgraduate training in obstetrics and gynecology in the UK, mainly in the Yorkshire Deanery, which is where he finally settled, and he has been appointed a consultant in obstetrics and gynecology since 2018. So he brings with him well over a decade of experience in the field. He is a consultant at the Mid Yorkshire Hospitals NHS Trust, which is a regional endometriosis center. And he maintains his touch with academia by being an honorary lecturer at Hull and York Medical School. He is a member of the British Menopause Society and also a member of the British Society of Gynecology Endoscopy. In addition to all of this, he has a degree in medical law, a qualification which he obtained back in 2010. Amongst his special orders, he lists interest in benign gynecology disorders, including endometriosis, menopause, and menstrual disorders. In his spare time, I know he plays golf, and he's also an avid runner. And one thing I've got to say about Alex is that he also supports the endeavors of Nigerian doctors in diaspora. He's very active in MANSAG, which is an association of Nigerian medical personnel in the UK, and he's been instrumental to delivery of a number of conferences by that organization. This afternoon, he's taken a break from all that and given us his time, and he will share his expertise on the subject of kidney disease and the menopause. So I'll hand over to you, Edosa.
Yeah. Theo, thank you very, very much. And Hilary, thanks also for the invite. It's a privilege to be given the opportunity to have this conversation with women who have kidney disease and who also have transplant. Like Theo said to you, I spent the last 25 years of my life being a doctor, and in the last 13 years, I've been a consultant in obstetrics and gynecology. my present daytime job, it's more focused on chronic pelvic pain, endometriosis. And for some of these women, to manage endometriosis, we have to take their ovaries out and create a surgical menopause. So menopause is an area where I do have a special interest, and I spend a lot of my time working with patients to help manage the menopause symptoms for them. I've been told I've got about 30 minutes to have a conversation with you about managing menopausal symptoms in women with chronic kidney disease and transplant. To talk about this, you're going to need loads more than 30 minutes to do that. So I'm going to try and do as much good service as I can within 30 minutes. But I'll be happy to spend as much time to answer questions, and happy to come back another day if there are more other questions we need to have resolved. So I'm going to start by sharing my slide, if it's okay with everybody.
So whilst we're sorting out the technical issues, if I may just ask you, Hilary, if you want to come back online, and just it's a topic which, as an orthopedic surgeon, I just have no knowledge about: menopause and kidney disease. What prompted you to look for this as a topic?
Actually, I am a transplant patient myself, and since I am close to that menopausal age, and then listening to other patients ask questions as well, and the people who support in the community asking questions regarding that, especially those young people of childbearing age. And it was a topic that people just kept talking about. And I thought, look for somebody who would come on and who would be able to speak on that subject, and probably allay some anxieties and worries. And for me, I will be learning a lot of things today, because I'm a transplant patient, and this is one of my worries. Even if I'm close to that age, I just feel that, it's the more information you have, the more you'll be able to deal with the symptoms. So we have Alex back now. And
I think I'm good to go. See if this works. Fingers crossed. Can you see my screen?
I can see your screen. I think you're good to go.
Good to go. Okay. So today, what we'll be talking about is more focusing on how best to manage women with the menopause. And when I spoke to Hilary about this, what she's asked me to do was to address certain questions, which I'm happy to do, and I put that as the learning points for today, the learning objectives for today. I think still having some technical issues, which I hopefully will sort out soon. If this works. Great. Can you see this?
Yes.
Yeah, I can see that. That's
so. This is what I'm going to talk about for the next 30 minutes about what is menopause and how chronic kidney disease triggers early menopause in some women, and the effect you can have menopause has on your long-term health as a woman with chronic kidney disease. And finally, we will conclude by having an overview of what the management is for menopausal symptoms in women with chronic kidney disease. So, what is menopause? And that's the challenging questions I find with lots of patients and friends who are women who they think are maybe menopausal. And I tell a patient it's technically menopause means there's a permanent cessation of your menstruation, which is caused by ovarian failure. And it's usually a retrospective diagnosis where the woman has had no menstrual period for 12 months. So she's not pregnant. She's had no menstrual period for 12 months. And you can back that up with high levels of FSH, which is your follicle stimulating hormones. So we got strict criteria for the diagnosis of menopause. But you could have the perimenopausal symptoms, and I'll go talk about that much later. We know that women with chronic kidney disease do have menopause, And if it depends on which literature you read, the numbers vary between 12% to 27%, 28% of women with chronic kidney disease having menopause. And for these women, the menopause tends to occur at the median age of about 45.9 years, which compared to natural age of menopause for women without chronic kidney disease or end-stage kidney disease, which is about 52 years. So you tend to go menopausal or turn menopausal 5 years before other cohorts of women without kidney disease. And that's very important, because when we go to talk about the impact it has on your long-term health, it is something I personally think is important, and lots of people, even including your renal physicians, your specialists, are not aware of that or don't focus on it a lot. The other bit I need to just clarify, just a basic point, is about differentiating between what is premature, inverted commas, menopause, when the right term is actually premature ovarian insufficiency, and also early menopause. So if your menopause happens when you're less than 40, the technical term for it is a premature ovarian insufficiency. That's the right word for it. And we know it occurs in 1% of women, whilst early menopause, less than 45, would occur in about 5% of women. So women with chronic kidney disease that go on to develop early menopause, why does it occur? The truth is, we don't know. Okay, there's no good consensus on why women with end-stage kidney disease are going to have transplant have early menopause. We do know that having your estrogen in your system, it's really protective for women. So if you compare men with kidney disease and women with kidney disease, you tend to find the progression into end-stage kidney disease much slower for women compared to men. And that's assumed to be because of the protection you get from your estrogen produced by the ovaries. It works with the renin-angiotensin pathway for this patient. But however, we think that women with chronic kidney disease that develop early menopause, the reason that occurs, it's multifactorial. So there are two predominant theories for now, and that's what we hold in until. And I'm going to talk about that. So one of them is, and I'll start with the basics. In the normal system, your hypothalamus, which is somewhere in your brain, the tiny fancy part of your brain, stimulates your pituitary gland, which is another small organ in your brain. Your pituitary gland releases hormones that stimulate your ovaries, and then the ovaries will produce estrogen. And the way it works is, from the hypothalamus, you have this pulsatile release of hormones called GnRH, which is gonadotropin releasing hormones. It releases impulses about 60 to 90 seconds that stimulates the pituitary gland. The pituitary gland goes on to produce LH and FSH, which is luteinizing hormone and the follicle stimulating hormones. And that's what stimulates your ovaries. Then you have this backwards inhibition from the estrogen levels to the hypothalamus to say, hey, we've got enough here. So the pulses quieten down. So you have that every month that occurs. What happens in women with chronic kidney disease is that that pathway is deranged, and we don't know why. We think there's an inhibition. You have this high level of estradiol because of the poor filtration from your kidneys, and that's what inhibits the pulsatile release of these gonadotropin-releasing hormones. And therefore, the pathway between the pituitary and the ovaries becomes dysfunctional. So the women don't have regular ovulation. So for the younger women, you have anovulation, and at some point you have total lack of any ovulation at all. And we know that if you correct that in the younger woman, say you have regular dialysis or you end up having a transplant, you could correct that and you can start ovulating again. However, for some women, they develop early menopause and we don't know why. The other pathway is about prolactin. Prolactin is a hormone produced by the pituitary gland. What prolactin does, the key thing is to stimulate milk production and breast milk production in women. And so we know for women who suffer with infertility, if you have high prolactin levels, it does inhibit your ovulatory pathway. So with high level of prolactin, they tend to have anovulatory cycles and they have problems with fertility. And the way we normally correct that is give drugs called to inhibit the prolactin levels or reduce that, and the ovulatory cycles get corrected. Women with chronic kidney disease, however, have a reduced clearance of prolactin. So prolactin has this backward effect on stimulating your hypothalamus, and again impacts on the GnRH pulses that impacts on the pituitary and then goes on to affect the FSH-LH pulses, and its final impact is on the ovaries. So those are the two underlying theories for now that are predominant. It depends on which papers you read or which experts you believe. People will argue right away, but that's the predominant thing we're working with now. So in terms of chronic kidney disease and menopause, the jury is still out. We don't know a lot. And I spent some time going through the literature again when Hilary asked me to make this presentation. And what I find amazing, I use the word amazing, very polite words against very upsetting, is that there is so little amount of research for women with chronic kidney disease and menopause. We have a national consensus for the last 7 years from the NICE on how you manage menopause, standard guidelines. If you go through all the guidelines, there's no subsect of information on how you deal with women with chronic kidney disease, NSAID disease. It's none at all. And if you think about it, 4% of women would develop chronic kidney disease either in the menopause or before they turn and become menopausal. And they will still need some form of HRT or managing their menopausal symptoms. And there's no research. There's no focus on that. So, Hilary, I think that's another point for you to look at. Because will you be an advocate so we can get more research done in this? So I'm going to talk next about the effect that menopause has on your long-term health. I think this is important, especially for Hilary, when you want to become an advocate and why we should do more research. For every woman who goes through the menopause, the main concerns you're going to have is your vasomotor symptoms. And the cardinal features are having a hot flushes and night sweats. And if you say that in simple conversation on the street, it looks as if it's something very trivial. Hot flushes and night sweat. What's that? Get a handkerchief, get an air conditioner, you'll be fine. But if you're having night sweats, and you're waking up several times at night to change your sheets, or to sometimes have a shower, you will never have a good night's sleep. And over time, there's a cumulative effect of poor sleep on your general well-being. And what you will get eventually, you start having all the psychogenic features that come with that. You fatigue, you can't function well at work, you forget a lot. Okay, then your moods start to change because you start to question yourself. Why am I forgetting this? Why can't I do that? And you become irritable, which impacts on your relationship with your partner, your children, and your work colleagues. And people get this label about, oh, that's the mad woman, because you're quite irritable, and that's understandable. But it is due to having the menopausal symptoms. So to me, as a gynae expert, it's not a trivial thing to have, and I'm an advocate that women should be treated for it. The next symptoms that's predominant is about having the genitourinary syndrome in the menopause. About 5% to 10% of women would have that, where you can have increased urinary urgency, or this slight burning sensation of dysuria when you pass urine that doesn't respond to antibiotics, and have vaginal thinness that causes vaginal dryness, vaginal soreness, and pain with sexual intercourse. And that leads on to the next one about having this sexual dysfunction. Because if you got pain with sex every time, why would you want to have sex? So you're definitely going to want to avoid sex. And if you're avoiding sex, it can impact on your relationship with your partner. And so there are long-term ramifications of all of this, a woman's health and her well-being. But more importantly for me, it's the osteoporosis and the cardiovascular disorders you can get with chronic kidney disease. We know that men tend to have more of cardiovascular accidents in their 40s, in the early 50s as compared to women. After the menopause, the incidence of cardiovascular disease tends to match up between the men and the women. So we know that having the estrogen within your system does protect women. It gives that protection against developing cardiovascular disease. So it's like your myocardial infarctions, your anginas. It does give some protection. So if the average age is about 52, but if you got chronic kidney disease, that occurs to you 5 years before that. So you're 45, 47, you have a heart attack, you've got a young family to look after. Okay, so it's important we take that seriously. And I suspect a lot of your renal consultants would be way into that about helping giving treatment to have cardiovascular protections. Osteoporosis essentially is a thinning of your bones, which we all, well, most people would ascribe that to the older woman in the 80s and the 90s. But we do know that if you have early menopause, which most women with chronic kidney disease will have, the risk of developing osteoporosis becomes much higher. So with osteoporosis, you're going to have fractures. And if you do have a fracture of your hip, statistically, your life expectancy drops significantly. Theo will be quite happy to give us the exact data on that. But what I know for sure is that compared to people without a hip fracture, if you do have a hip fracture, which is osteoporosis, it does impact on your general well-being, your health, and also your mortality. It's much sooner compared to people without osteoporosis and hip fractures. So it's important that we take on these effect that the menopause will have on your long-term health quite seriously. And I'm pleased we're having this conversation today, which means people are getting more informed. And I would hope that when you go speak to your renal physician at your next clinic visit, you have that conversation with them. Is there anything I can do now before I achieve menopause to prevent me developing osteoporosis early or the cardiovascular disorders that could occur when I do become menopausal? Have that conversation with your GPs. And if you're ready in the menopause, then have a conversation about what's the benefit I can get. How could I manage this better to help me resolve my vasomotor symptoms? If I've got genitourinary syndrome of menopause, to deal with that, osteoporosis, and cardiovascular disorders. So I think it's important you have that conversation with either your GP, who's your primary caregiver, or with your renal specialist. So let's talk about the vasomotor symptoms, because this is the predominant thing, and I'm happy to have loads of conversation as much as we want to have on this. We know it's likely due to the estrogen withdrawals, okay, not necessarily deficiencies, because some women would have low levels of estrogen with these pulsatile patterns as they approach the menopause. So you could be 47, still having irregular periods and have the hot flushes and sweats. Historically, some doctors have said, you're not in the menopause, I'm not treating you. So you suffer until you have 12 months without the period. Then you're not in the menopause, then I can treat you. But I think my college, the NICE guidelines have changed all of that. You can treat women for menopausal vasomotor symptoms if the symptoms are in keeping with what you think could be associated with the menopause. It is usually said to be centrally regulated, and it predominantly occurs with the flushes and night sweats, and which does have a significant impact in your ability to concentrate and also your mental and physical well-being. Most data will say that the symptoms will last for 1 to 4 years, and very rare occasions can be as much as 10 years. But in my clinical experience, I've seen a woman who's 75 and come back to have the HRT because her GP stopped it, said, in your 70s now, you don't need the HRT. And her life was miserable. The flushes and sweats came back. And so she went back on the HRT and the life got better for her. So yes, in theory, 1 to 4 years, most women get resolved, but for some women, it could drag on for the rest of your life. So in my practice, I don't have a fixed time where you can stop the HRT. But what we do know that if you're going to get the maximum protection from going on HRT, you need to have it within 10 years of becoming menopausal or less than 60. So with the genitourinary syndrome of the menopause, it normally affects, like I said earlier, the labia, the vagina, the urethra, and the bladder. And we know for that for sure is secondary to estrogen deficiency. And we know that for sure because once we can replace or give topical estrogen to majority of these patients, they do very well and it resolves. So they present with genital irritation, they can have vaginal dryness and pain, and which tends to resolve with treatment using topical estrogen. But the key thing is ruling out the fact that these women haven't got any other causes, so you can have urinary tract infection, or women can have inflammatory conditions that involve like lichen sclerosis or lichen planus that can be causing the pain when they have sex. Sexual dysfunction in the menopause, it's quite multifactorial because yes, with chronic kidney disease, you can have all of these effects where you fatigue from your dialysis, of your general health and well-being. You can be stressed from dealing with life itself, dealing with managing hospital visits and all of that. So that could lead to depression and anxiety, which definitely puts having sex at the bottom of your priority every day or for the rest of your life. But it's still important that if we can provide patients help to reduce the problems of having sexual dysfunction for the menopause, and that's one little help out of the way. So we know that if you do have estrogen deficiency with the genitourinary syndromes, you could impact on your ability to enjoy sex. So the sexual desire is definitely reduced. So you have that reduced sexual desire in these women. And for some patients with the pain, there's less of the arousal, there's less of orgasm for these patients. So it's quite a multifactorial thing. But like any other woman, with or without chronic kidney disease and the menopause, you potentially could have sexual dysfunction. It's important you're open to your GPs about that and have that conversation. And most GPs now, if they can deal with that, will be able to signpost you to either to a gynecology service or to a psychosexual counselor to help you with all of that. So good. Next few minutes, I'm going to be talking about how we'll manage the symptoms, menopause, and that would still relate to women with chronic kidney disease. Earlier, I said that we have no national guidelines on how we manage women with the menopause and chronic kidney disease. We do have a national guideline, however, which is a nice guideline from 2015, which the British Menopause Society still uses on managing women with the menopause. So what I've done, it's reviewed the literature on chronic kidney disease and look at how on menopause management and think it through that the treatment or drugs we use to manage the menopause, would that impact on your chronic kidney disease? Will it impact on the drugs you use, or will the drugs you use for managing your chronic kidney state or your transplant, will that impact on your HRT? So we know that having estrogen is renoprotective. So it does reduce the rate of deterioration of chronic kidney disease. So it's a good thing to have that. And we also know that the estrogen you get, if you're going to go down the line of having HRT, shouldn't impact on your kidney function itself. But there is evidence that having HRT does sometimes impact on other parts of your well-being, such as your hypertension, or more importantly, your risk of venous thrombosis. So my approach to managing women with the menopause symptoms would be first to go into a normal clinical assessment of these patients, and which would include taking a detailed history, what are the symptoms they have, and what's the main worry they have about the symptoms, how does it impact on their quality of life. And then to focus on their gynecology and medical history. In this case, about your chronic kidney disease, you need to know at what stage of chronic kidney disease the patient is at, end-stage disease, or had the transplant, and what drugs the patients are. It's about reviewing all of that. And most importantly, their family and social history. So if you've got a family history of a cancer gene, so you got a BRCA1 and a BRCA2 cancer genes, which we know that if you do have that, your risk of developing breast cancer is close to about 50%. The background risk in a woman is about 3%. So you got a massively high risk of you developing breast cancer. And we do know having HRT could increase your risk of your background risk. So if you're starting with 3% and you're increasing the risk, it's so much different when you're starting with the 50% and you're increasing the risk, which more than that. So physical examination for women in menopause is not a priority per se, especially if they don't have the genitourinary symptoms. If they do have that, then it's worthwhile examining the vulva and the vagina area to make sure there's no other local pathologies causing the symptoms that you can easily deal with. So for most patients, it's good enough just taking a detailed clinical history. And that's because every aspect of the history will be important in helping you manage this patient. Make a diagnosis of the menopause. Like I said earlier, in the past, we worked on the fact that you go to blood tests, so you have some doctors doing loads of blood tests to find out if you're menopausal. We don't necessarily have to do that anymore. So if you're more than 45 and you've got the perimenopausal symptoms or the vasomotor symptoms, irregular periods, that could be perimenopause and you can have treatment. If you've had no menstrual periods for 12 months in addition to these symptoms, then you're definitely menopausal with the symptom and should be treated. We do not have to do blood tests. The recommendation to consider blood tests, which is the follicle stimulating hormone, the FSH. There's no need to do your estrogen levels. FSH will be fine. There's no need to do your thyroid function test, except your GP has concerns to worry about you having a thyroid condition. So women less than 45 with menopausal symptoms, then it's worthwhile doing the FSH levels. And you may want to do that 2 tests about 6 to 8 weeks apart. And if the levels are consistently above the 30 nanomoles levels, then you can say this patient could be in the menopause. And the same thing works with women with premature ovarian insufficiency, so who are younger than 40. You definitely really want to do the blood test for them, the FSH levels, to make a diagnosis. In addition to that, you want to make sure there are no other conditions causing their ovaries to stop early. So if we assume we've made a diagnosis for the patient, then we're going to think of how best to manage the menopause. Menopause essentially is a period where your ovaries stop to function. So they stop producing estrogen. For every woman, majority of your estrogen comes in from your ovaries, and the rest amount comes from either your adrenal glands or for your body fat. And so replacing what you're lacking, it makes common sense to give what's missing, which is the estrogen. So traditionally, we've always given estrogen or estrogen and progesterone as hormone replacement therapy. All the evidence with all the randomized controlled trials will support the fact that the best outcome in terms of dealing with your menopausal symptoms comes from using estrogen as estrogen replacement therapy. So the non-hormonal treatments do help resolve some of your vasomotor symptoms. The herbal remedies could help, but in majority of patients that have menopausal symptoms, such as the vasomotor symptoms, in over 85 to 90% of the patients, estrogen, HRT, it gives the best outcome. So there are massive benefits to having the estrogen and estrogen, progesterone, HRT. And I keep using the word estrogen and estrogen, progesterone, HRT, because for women with the uterus in place, you need to have progesterone in addition to estrogen as your estrogen, progesterone, HRT group. And the reason we do that is the estrogen will stimulate the lining of your womb, and without any progesterone, you could have an excess stimulation of the lining of your womb that could lead to you forming endometrial cancer. So with the progesterone, which you need to have either on a daily basis or for 10 days every month, it will protect the lining of your womb and drop your risk of developing ovarian cancer. Estrogen only HRT is therefore advised for women who've had a hysterectomy. So that's the key thing. And if you can see the slide, I've got the picture on the right side. It's quite small, and I apologize for that. And that's the simple algorithm we use. If a woman has had a hysterectomy, it has to be estrogen only. If she's still got her uterus in place, you need to give estrogen and progesterone. So I'm going to talk about a woman with her uterus in place, which most women will do. If they're still perimenopausal, so they're still having their periods irregularly, you need to give them what we call a sequential preparation of estrogen and progesterone, HRT, so they will still have regular monthly periods. Or if the woman has stopped having a period for 12 months, You don't want to give them estrogen and progesterone that could stimulate periods again. So you give them what we call a continuous combined HRT. The continuous combined HRT would certainly ensure they don't have regular periods. They have no periods whilst on the treatment. How you give it could either be as oral preparation or what we call a transdermal preparation. And that's a conversation you can have with the GPs. And I can talk to you why we do all of that. So we know that women who are on HRT, especially the estrogen progesterone HRT, or even the estrogen-only HRT, your risk of having venous thromboembolism is slightly higher than the general population. But we do know that if you compare oral preparation to giving women transdermal preparation like the patch, the gel, or the cream, the risk of venous thromboembolism is much lower. It's quite similar to the general population. So for example, say if I had two patients, one patient had a history of deep vein thrombosis in the past, either were pregnant or from a road traffic accident, she comes with HRT much later in her life. My emphasis would be on giving her the transdermal preparation. So if she's overweight, she smokes, I'll be going towards transdermal preparation. She's diabetic, transdermal preparation. But if she's of normal BMI, no background history of DPT in herself or in a family, I'm quite happy and flexible to give her either of them. She can have oral preparation or a transdermal preparation. And that's the key thing. The next is to talk about breast cancer, because that's a big issue. When you talk about HRT, the first thing that comes to everybody's mind is breast cancer. About 20 years ago in Leeds, we were giving out HRT like Smarties to patients. And lots of doctors, lots of farmers were making money selling HRT. Then a big study came out where the Women Health Initiative came out and said, having HRT doubles your risk of breast cancer. That was the Daily Mail's headline, doubles your risk of breast cancer. And the market dropped. Patients were coming back to our clinics, having reviews and refusing to take HRT. They were quite happy to suffer with flushes and sweats, expose themselves to risk of osteoporosis, as long as they didn't have breast cancer. Because everybody thought having breast cancer is a death sentence. Medicine, it's a wonderful science. It's about going back, looking at data, looking at the research, and coming up with new information. So in the last 20 years, people have gone back and looked at the WHI study, and they followed up patients with different researchers all over the world. And the consensus now is that having estrogen-only HRT does not increase your background risk of breast cancer. Having estrogen and progesterone HRT does increase your risk, the background risk of breast cancer. So, now put this in simple terms. If you have 1,000 women who are over 50 on HRT, estrogen and progesterone, and another 1,000 women over 50, not estrogen and progesterone, if you follow them over 5 years, the cohort of women not on any HRT, about 24 will develop breast cancer. The cohort of women on HRT, 27 will develop breast cancer. So we're looking at from 0.24% to 0.27%. So there is a slight increase. But by how much? In relative terms, the numbers are small. But you cannot tell a patient it does not increase your risk, because we know it does increase the risk. But in real terms, it is really small. And that's important to tell my patients. And so in my conversation with the patients about risk and benefit, it's would you rather have the benefit of improved vasomotor symptoms, improved quality of life, improved mental well-being, as against not taking this when you know your risk of developing breast cancer in the next 5 years is just slightly higher than your background risk even without this drug. And more interestingly, if you were obese and you did not take HRT and you're over 50 in 5 years' time, your risk of breast cancer is far more than your risk of developing breast cancer if you were not obese and you're on HRT. And that's what I tell my patient is walking through the numbers yourself and see how you can balance the risk and your benefits to yourself. So that's the key. So the emphasis now is, yes, there is some risk there. There's a potential breast cancer, but how high is your individual risk? And that should be the way you make a decision if you're going to have HRT or not. The other concern is about how long am I going to be on HRT for? And my emphasis to patient is and that there's evidence to back this, there is no science to say how long you should be on it for. 1 year, 2 years, 4 years, or 5 years. We don't know now. So what we know is that if the longer you are on it, your risk of breast cancer goes slightly higher. And if you stop it, your risk comes back to your background risk. So I tell my patients, start on a HRT, get reviewed by your GP in 6 months, get reviewed every year, and subsequently every year you get reviewed. And for the review visit, it's about having this conversation. How am I doing? Is it working with my symptoms? Do I really want to continue with it? A reminder what the risks are. If there's any new information about risk, you can get that from your GP. And if your risk is minimal, you can decide you want to continue with it. Go ahead and do that. Before I move on to the next slide, it's just a one proviso here. All the data we have, even from the WHI study, were for women over 50. So all the research is done for women over 50. So all I've said to you about increasing your risk of breast cancer does not relate to women less than 50. So if you're 40 and you go into menopause, starting HRT does not increase your risk at all, either estrogen or estrogen-progesterone HRT. We have no evidence for that. All the evidence we have is about women having HRT and the risk of breast cancer over 50. So in my endometriosis clinic, women who might create a surgical menopause for because it's necessary, I'm quite free about putting them on HRT. And when they get to 50, we start to have that conversation about, do you want to continue HRT or not? For the women with genitourinary syndromes of the menopause, you can use topical estrogen in the vagina or the vulva area. And so, for example, to a woman, if her main concern is about vaginal soreness, dryness, but she has minimal hot flushes and sweats, and she's not bothered about that, then it's worthwhile just dealing with that. You can give the vaginal estrogen. The vaginal estrogen will work locally. Very, very small amount gets absorbed into the system. It's virtually insignificant amounts, really. And that's why your risk of breast cancer is not changed at all having vaginal estrogen-only cream. For women with the uterus, yes, you can still give it. But if they do have any regular bleeds, they need to be referred, and you need to ask your GP to refer you on to be reviewed in a hospital to make sure we don't have any excess endometrial stimulation. Some patients, however, will decline to have any estrogens and are put in the right part of the slide there using moisturizers or lubricants to help, or you can use both. So it's all open out what you want to do, and it's safe. So in the last few minutes, what I'll try to do is essentially talk about menopause and how it affects you with chronic kidney disease or with transplant, and what information we have there and what treatment you can have. But for me, the most important thing, and I hope you can take this away, is that if you have the menopause symptoms or you're in the menopause, have the conversation with either your GP or your renal physicians about treatment. It is safe, in my opinion. The benefits far outweighs the risk to yourself. It gives you the benefit of reducing your vasomotor symptoms, which improves your quality of life, not just work life, family life, and having sex with your partner. It does offer you protection against osteoporosis, and most importantly, it reduces your cardiovascular risk until you hit the natural age of menopause, which is over 52. Thank you very much, and I'm quite happy to answer any of your questions.
Right, thank you very much. That's a very, very, very comprehensive, very, very comprehensive discourse on a topic which, I feel say very little about up until about just after 4 o'clock. But so I just want to pick you up on one thing. You mentioned that when you have chronic kidney disease.
Yeah.
It can bring on premature menopause.
Yeah.
If you have a transplant,
Yeah.
does that change? Does it take you back to, not having a premature menopause, or is that still there?
Theo, we didn't know that. That's an interesting thing. And I spent lots of time trying to look through literature. If you have irregular periods, okay, anovulation, you're ovulating and you get infertility, and you're going to have a transplant, everything resolves.
Oh,
It does resolve. But what we do, if you develop menopause where your ovaries somehow shut down, even with a transplant, it doesn't correct itself as much. The reasons for that is something that nobody's going to find out. And that's why I said that it's just so little amount of research being done. I've tried to look for the data out there to find out transplant for kidneys and resolution of menopausal symptoms. I can't find it.
I mean, that's interesting. It's one of the things that I think Hilary is quite passionate about, this idea of transplant first. So a lot of people in the UK, when they have chronic kidney disease, end up needing some kind of replacement therapy, dialysis, hemodialysis or peritoneal dialysis, up until the time they need transplant. And people are now thinking if you actually put the transplant in earlier, it helps for a host of other problems that they have. So in terms of, you've talked a lot about the medical treatment of menopause, the medical treatment of the symptoms, but things like osteoporosis and cardiovascular problems. What about the role of exercise, weight-bearing exercise, diet, activity? I know it's difficult for people who are coping with transplants to maybe go on to, the gym, etc. But does that play a role in your management of osteoporosis? Of the menopause?
Absolutely. It's a capacity conversation I have. It's quite a difficult conversation having with an obese woman with the menopause symptoms. But having it with an unobese person, lifestyle changes should be the starting point, because we know with regular exercise, you're releasing loads of endorphins, and that does help improve your well-being. Because one of the non-hormonal treatment for women with menopausal symptoms is actually putting them on the antidepressants, the SSRIs, so like venlafaxine, paroxetine, fluoxetine, even gabapentin has been shown to improve your symptoms by about 40 to 50%. And that's the bit where if you do regular exercise, you have lots of endorphins in your system, it does improve all of that. You have to stop smoking. So if you smoke, that's a no-no. You got to stop smoking. But it's easy said and done. People struggle to stop smoking. Caffeine, you've got to just abolish it, not just even try, just abolish it. It's totally out of your diet. Alcohol, you need to minimize it as much as possible. There are things you can do, and there's evidence about cognitive behavioral therapy. I think more recently, people were talking about acupuncture helping out with menopausal symptoms. But sadly, the randomized controlled trials they've done looking at acupuncture has showed it's the same as placebo. But if you can afford it and it works for you, go ahead and do it. But the NHS will not fund acupuncture for you, because they will throw out the literature. Yes, so look, the RCT shows it makes no difference. But I think for some patients, it's massive benefit to them.
Yeah, I mean, I think we find that with acupuncture and maybe a host of other treatments. And what I always say to patients, if it's not available on the NHS and they feel very strongly about it, well, find a practitioner, try it and see if it works for you. If it works for you, it's worth persevering in.
Absolutely.
One thing you mentioned about the risk of stroke.
Yeah.
So the risk of stroke goes up with menopause.
Yeah.
But also, if you have hormone replacement therapy, it can increase the risk of a stroke event.
Yeah, what the research shows now, Theo, is that for women who go on HRT after the age of 60, it does increase your risk of stroke.
Okay.
But if you go on HRT within 10 years of being menopausal or before the age of 50 or 60, your risk isn't increased at all. It's interesting how the patient recently who was actually 59. So we had this interesting conversation just 1 year before the cutoff. Should you go on HRT or are you actually 60? She's going to be
Yeah.
60 in December.
Yeah.
So is she 60 minus 3, or is she 59 plus 7? So at the end of the day, we're on the balance of 8. You're going to have the hair chart for the next 3 months and see how you go. Review in 3 months' time when you're 60. And then you need to make a decision. Because if it's improved your quality of life,
Yeah.
then you need to make it say, well, what am I risk of having stroke? Background risk in the general population of having stroke is quite small.
Yeah.
If you are not overweight, if you don't smoke, you don't drink excessively. So if you can reduce some other background thing that can increase your background risk, having a HRT shouldn't make it worse for you. But if you were overweight, you've got significant comorbid like diabetes that's poorly controlled, then I have concerns about even starting you on it.
So it hinges once again on early recognition and starting treatment early,
Absolutely.
rather than waiting until. So
Absolutely.
if you start getting symptoms with the menopause, hot flushes, psychological symptoms, etc., and you decide to ride it out,
Yeah.
what happens? If you say, I'm not interested in seeing a doctor, does it go away?
Well, we know, yeah, it does go away. It does go away because the evidence shows that most women would have it for 1 to 4 years.
Okay.
A small proportion of women will just drag on. And that's why I guess over time there hasn't been so much emphasis on the menopause because it's been a woman's thing. And I was speaking to a colleague recently, and she says it's something that impacts on your life at the twilight of your career. So you're approaching 50, the kids are out of the house going to schools or starting their whole lives. You're rising up to the place of work. Most people in the late 40s become higher up in their careers. You have to look after your parents, so they got all the stresses come in, and then you're having poor sleep. You're sweating at night. You can enjoy sex with your partner.
Yeah.
You're going to ride that for 4 years.
Yeah, I mean, I think
That's a turbulent ride. That's a turbulent ride.
Yeah. I mean, I can see what you're saying. I mean, if you look at economic data, it says, usually your maximum career potential is about 49, about the age of 49. People hit their peak, and that's when you need to have everything on your side. You don't want to deal with hot flushes and sleepless nights and things like that. Somebody has said that they highly recommend, I think this is in relation to exercise, something called Kidney Beam. That's as in, beam as in a beam of, I guess, free online exercise classes for anyone with any stage of kidney failure, and they're live and on-demand classes. Now, there's one thing I think I should touch on, because this is, tailored towards people from minority ethnic group, and I don't know how many of your patients come from that background. You mentioned something about genetic susceptibility to breast cancer and the family history.
Yeah.
One thing I know about knowing your family history is that it is often not quite as good with patients of an ethnic minority background. How well do you think people are aware of this gene being in their family that can give you a 50% risk of breast cancer in the ethnic minorities?
I think in the ethnic minority groups in the UK, a significant proportion of the women are aware.
Okay.
But when it comes to ethnic minority, the Black women in Nigeria, that's a totally different ballgame. I said that because I think a few months ago, I saw it last year with the lockdown and Black Lives Matters, myself and a colleague did a survey on Black women and menopause symptoms. And what I found interesting is that most of them, their presentation, they weren't too worried about the vasomotor symptoms at all. I think half of the survey respondents from Nigeria, there were more concerns about the fatigue, the muscle aches, and joint aches. And I guess Nigeria is a hot country, and a lot of people just sweat and get a handkerchief. It's a cultural thing for Black women to have a carry handkerchief or something, but it's for the Caucasian population, it's not. And you're right. Most of my patients here, I'm in East Yorkshire, so most of my patients over time are Caucasians. And I find that a challenge when you're asking a history from women for ethnic minorities about the family history of breast cancers. They struggle with it, but I think from my experience dealing with UK-based patients, some of them know.
Okay, I mean, I think that's that's very, very reassuring. So, thank you very much. I'm going to just try and summarize what you've told us now, maybe some living tips for Hillary. So it's all about chronic kidney disease and the menopause. And I didn't realize that there was a direct link. But what you've said is that it can trigger early menopause, but the cause is not really known.
Yeah.
And there's not a lot of research that's been done into it. So when we're thinking about research priorities, Hillary, maybe that's something that you can push on to people on a national basis, that there's not much known about the relationship and how it actually happens.
I've just done that now online.
Yeah. And I think also what I'm hearing quite strongly is that you should initiate this discussion early with your GP and or your renal specialist if you think you're having symptoms of the menopause. And you don't have to wait until you have 12 months of no periods. You can start the discussion if you think you have those symptoms, and you can start to get treatment. For treatment, for symptoms which are localized more to the genital region, estrogen creams work very well, and tablets are generally not required. Work out if you have a family history of breast cancer, because that's very important in terms of the treatment that you would get. And also, if you have a history of things like deep vein thrombosis, blood clots in the legs in your family, maybe avoid the tablets, maybe a patch is better. But in taking all these decisions, which all seem to be very complicated, you need to be having discussions with your doctor and also with your GP and also your renal physician. Thank you very much for taking the time out to educate us on a very tricky topic, and one that I hope I don't have to deal with as I hand over to final remarks.
Yeah, thank you very much, Theo, and thank you very much, Alex. Now, there were some questions in the question and answer section. I don't know if you touched on that. Lucy said, "What about the role of testosterone?"
Okay, do you want me to answer that?
Yes, please. Yes.
Okay, I think there are two ways you can look at that. I think for me personally, I think if you have issues with libido and it's related to menopause, testosterone would help. The challenge is there's no license for testosterone use in women in the UK. It's licensed for men, but not for women. So there's no manufacturer selling it for use by women. So what we'll do, you will need to see, so your GP can prescribe it for you. You have to see a menopause specialist, and they'll be happy to prescribe it for you because they would have to monitor you. You have to have your blood testosterone levels monitored at the baseline and on a regular basis whilst on the testosterone. The main drawback about it is the potential side effects. So you will develop some degree of androgenization, so there'll be increase in body hair growth, sometimes in the male pattern. And I think more worrying is the voice change. And if you're on high doses and your levels are too high, it could impact on your voice, and you can't reverse that, I'm afraid. So that's the big issue that women have. And if you think about it, medicine is still very fraught with some pitfalls where you can get bite back for when things go wrong with patients. And if you can reverse something, it's easier to help the patient out. But if you can't reverse it, it's a long-term issue, and that becomes a concern. When I presented the slide on the sexual dysfunction you get with the menopause, it's so dysfunction. It's so multifactorial that people assume it's all about giving me testosterone, I'll feel better and I'll be okay with libido. Having any significant medical condition that long-term does impact on your well-being. Poorly controlled diabetes, if you have a cardiovascular event, myocardial infarction, if you got chronic or end-stage kidney disease, you'll be tired from the dialysis or the drug treatment and everything. Is that what's dropping your libido, or is it lacking testosterone? So it's about finding exactly what's causing the low libido first before you start testosterone, where you find there's no other reason, it's got to be the menopause, then you can try it. But you have to try it with the proviso there are potential risks to yourself. So you will have it prescribed by a menopause specialist, and he or she will need to follow up on a regular basis.
Okay.
Sorry, I'll just
go on.
No, if you finish up on that point, there's just one last comment I wanted to address.
Okay, so I was just gonna ask. So if it affects the tone of the voice. So for instance, like me, I talk like a woman. So if it affects my voice and it changes to a man's, I won't be able to change it later.
No, you talk like me.
Oh my God. Okay, that's bad. So what do we do in that instance? What do we do?
Yeah, and that's why that's why we have to monitor the levels.
Okay.
So as long as we keep it below a certain level, your chances of that it's very low.
Okay.
But the challenge I've had personally dealing with patients, I would only prescribe it when I've developed a trusting relationship with the patient that she's going to come back and have all the monitoring. Yeah. Some patients get better and they just disappear. Okay. So one of the things you do, you try and restrict their prescription to either on a monthly basis or every 2 months. Okay. So that every time they come, they do the test first before you prescribe the next one. So that's the challenge you always get, because you get your indemnity as a doctor, all that, and you have to be careful about what you do and how you prescribe, because an off-license prescription.
Yeah. Okay. Okay. Theo, do you want to ask a question, because there's some other questions on here?
Yeah. So I mean, there's just a comment that HRT is no good and the side effects are way too severe, and I don't know if you want to just because you talked extensively about the use of HRT, but someone says the side effects are way too severe.
I think I would say that from my experience, and also if you look at all the high quality research data, having estrogen, progesterone, HRT is still the best drug treatment for menopausal symptoms. Yeah, if you're worried about osteoporosis, there are alternative drugs. We know the bisphosphonates can help protect your bones. We know that for sure. For cardiovascular protection, we know the statins could be used. Living a healthy lifestyle could be done. But for the vasomotor symptoms, the alternatives, like I said, you can use the drugs like venlafaxine, you can use gabapentin or clonidine, but they will drop your symptoms down by, say, 40 to 50%. So you've got something that can give you 85 to 90% reduction in symptoms, something that can give you 40 to 50. It's a choice thing you're going to make. And to me, that's the most important thing when you speak to your GP or a menopause specialist. It's about having all the data on the alternatives and how well they will work, and you make a decision. For some patients, having the 1% increased risk of having a 0.1% of breast cancer scares them. They don't want to have that. Okay, they'll be happy to ride the next 4 years. Not an issue at all. It is still a quality of life condition. And that's why choices matter. So if you will say you had cancer or you've got end-stage kidney disease, your choices are limited. The transplant is offered to you, you take it. But this is a quality of life thing. A lot of women are not on HRT and they still have good quality of life. But some women will have debilitating symptoms. And I just think it's a disservice to them not to have that information and offer there for them to use.
I think there's one more question, and this is from Lucy again. She says, I am post-transplant and HRT did nothing for me. What else can I try? My nephrologist ruled out any supplements for night sweats except evening primrose oil.
Okay, I guess it's unfortunate that Lucy hasn't had any benefit from it. What I would like to ask is, was she on maximum dose of the HRT? Because we normally will start you on your lowest dose and gradually step it up. So she needs to ensure that she's on the maximum dose of the HRT. Then the other things to look at, was she on oral preparation? Because there are various things that could affect oral preparation. Or was she on a transdermal preparation, which gives a better bioavailability within your blood with the dermal preparation? And she needs to look at all of that. And then she can add the non-hormonal treatment. So she can add things like gabapentin or fluoxetine or venlafaxine. This would sometimes help patients dealing with the vasomotor symptoms. But like anything else in medicine, for some patients, you struggle to find what's right for them, and you just can't provide answers. So as I said, it doesn't give a cure for 100% of patients. You're going to have about 5 to 10%. It makes no difference no matter what you do.
And the last question from Jill. Jill says, I'm worried about osteoporosis. I was taking off my calcium tablets as it impacted on my kidney function negatively. What would be your advice?
I think it's important she has a medical history reviewed again. The calcium, yes, will affect on your kidneys, but she will need to have some form of protective treatment. So she can consider going on HRT, which would help give some protection. It's not the first line. She can have a chat with a nephrologist about having the bisphosphonates, okay, or drug like that could help, because bisphosphonates are normally the first line treatment for patients with osteoporosis. So as long as that's compatible with whatever she's having for her kidney disease, I think that should be the first thing she wants to do if the emphasis is just on osteoporosis.
Okay.
Yeah. So thank you. So with respect to osteoporosis, people who have kidney disease and who have transplants are their specific risk group. And if you've been taking off calcium, I think there are a few things you might just want to think about. Okay, first of all, the lifestyle changes that Alex has talked about. Look at your activity and look at your diet, weight-bearing activity, because you need to maximize those kind of things. The second thing is that if you so you're worried about osteoporosis, you can have a DEXA scan, and that will quantify whether or not you are normal bone density, in which case you need to maintain it. You're going down, in which case you need to think of what you need to do to stop that going into osteoporosis. Or whether you now have frank osteoporosis, in which case the options you start looking at the other second line, third line drugs if you come off calcium. So if it's of concern to you, the good thing about bone is that bone takes a long time to change, either to build up or to dissolve. So you've got time. Speak to your GP, speak to your renal physician, have the tests, make your lifestyle changes. There will be a solution.
Yeah, thanks, Jay, for that.
Straight into bone health.
Straight into your area.
Well, we might be thinking about that next, looking at bone health, Theo. So get ready. We might be putting you on soon, because it seems as if, we might need something from your side of expertise. So thank you, everybody, for coming today. We are at the end of the session. And once again, it has been an interesting 1 hour. I wish it didn't have to end. I'd like to thank Alex for taking the time to speak to us about understanding the early onset of menopausal symptoms in women with end-stage kidney disease and transplant. It has really been informative, and I hope everybody learned something today, and I think I did. I cannot finish without thanking all of you, our audience, who have come online today to listen and ask questions. You have been really amazing in wanting to know more. Menopause is a condition that needs to be managed, and it causes distress even when a woman is of age. But prematurely entering menopause, especially in young women, is troubling, and it causes a lot of worry. It's the worry that comes with it, really, especially when the young woman has no children. However, having Alex here to talk to us today about what to expect and how to manage it is a blessing. There is another thing that keeps people awake at night, people on dialysis. It's about getting a transplant. Being on dialysis is painful. It is living a half-life. And as a community, we do not think about organ donation. As a community, we do not consider organ donation. But now is the time to think about it. I will encourage you to sign up to the organ donation register here in the UK or wherever you are in the world. Try and see if you can do this. If you cannot do this, there are other ways you can help. You can volunteer to help raise awareness about organ donation or blood donation. The NHS BT has funded WSH BME Kidney Network to give funding to churches, small charities, radio stations, individuals who would like to raise awareness about organ donation. One example of a small effort you can do is to hold a small party, inviting your family and friends, and have a conversation with them about organ donation or about giving blood. If you would like to know more, send an expression of interest to hello@wshbmenetwork.org.uk. Until next month, the 25th of September, when we would have a consultant renal physician who will talk about kidney disease and transplant, pregnancy and childbearing. I say thank you to all of you for being with us today, and thank you to Theo for moderating this session today. We hope to see you soon. Thank you for being here. Goodbye.
Thank you.
Thanks.